Welcome, everyone, and good evening in this new night of Egyptian Society of Nephrology and Transplantation CME meetings. Today is one of our transplantation days, and we are going on our first sessions of regarding cadaveric transplantation. Today, our topic is about selection of cadaveric donor, and this we will speak about an important topic, which is diagnosis of brain death. Let me welcome our moderators and our speaker today. Our moderator, Professor Gamal Saadi, who is the past president of Egyptian Society of Nephrology and Transplantation. He is Emeritus Professor of Nephrology and Internal Medicine, Cairo University, and he is the current president of African Society of Organ Transplantation. And our co-chair and co-moderator is Professor Ahmed Abdelalim, is Professor of Neurology, Cairo University, and he is the head of Neurology ICU in Qasr Al Aini Hospital, Cairo University. And our speaker today is one of the best in this field. She is
You are muted.
We can't hear you, yes.
Yeah, I cannot hear you. I think you're muted. I don't know who has the power to unmute. Oh, he's unmuted now.
I hope we can proceed until Dr. Yasser can join again. And it's my pleasure to have our dearest friend and colleague, Dr. Chloë Ballestté from Spain. She is one of the main directors of the DTI and the main directors of the cadaveric program in Spain, which is one of the most famous programs worldwide. And actually, we are trying to imitate them and take their initial steps as a guide to us to start implementing the cadaveric program in Egypt. We have a lot of problems, and up till now, we did not implement the diagnosis of brain death regardless of organ donation in our intensive care units. And I'm really advocating to start this process and to have awareness of the diagnosis of brain death among the intensive care units, to have no conflicts of establishing declaration of death dependent on brain death criteria. And we will be highlighted from Chloë now about these criteria. And we are also considering to have our Egyptian standards, which would be acceptable on the cultural and social levels. And probably we might consider after diagnosing brain death, we might in some categories depend as well on circulatory death, which will follow the brain death. And probably it should be the uncontrolled form, not the controlled form of circulatory death, which is adopted in some Western or European countries. So the floor is yours, Chloë, to give us a highlight on the brain death diagnosis.
Thank you very much.
1 minute, please, Chloë. Professor Ahmed Abdelalim, are you with us?
Yes, Dr. Yes. I really have the honor to be among you today, and I welcome Dr. Chloë, and I have the pleasure and the honor to be with Dr. Gamal. I think this is a very hot topic for us because we all are in the situation of having a patient with brain death, and we don't have a clear criteria to really do that in Egypt. And then when it comes to the transplant, this is really a sensitive topic. So I think we're really eager to listen to Professor Chloë, and then discuss what we can do in the future. So thank you.
Okay, please go ahead.
So thank you very much, dear friends. I'm very honored to be with you. And I think that Professor Gamal already said many of the things that I would like to transmit today, no? So most of you are nephrologists, so the idea is that none of you should do the brain death diagnosis, but since you are the ones pushing to change the situation about disease donation in your country, I think that it's very important for all the community to understand the concept of brain death. And when we talk about brain death now, there are many new ideas that are coming, no? And then we cannot many people said that we cannot say brain death diagnosis, we have to say declaration of death under neurological criteria, etc. And in fact, it is true that that this concept is always in a dynamic way, no? To say it in a good way, because there is always controversial. And why? Because in the last 70 years, the concept of death by itself has changed a lot. During all the human being history, death was always when the heart or the breath stopped. But when we started having artificial ventilators is when everything changed. And the point here is putting together brain death and donation. And this has been the big mistake that we have been doing. But of course, we cannot deny the fact that we have defined brain death because of organ donation. Okay, but I will try to give you some international standards about brain death, and those are things that are the same here in Egypt, in Spain, in China, or wherever you go. This is a clinical concept, and this is really what I would like you to really understand. Of course, the brain death concept is important for all the healthcare community to be clear, because at the end, one of the reason why people do not accept disease donation in the family approach, no, when we approach the family, usually is because there is a misunderstanding of the brain death concept. And the point is that maybe we are not explaining that correctly. So when we talk to the families, we shouldn't talk about brain death as a first step, but we should announce the death of the person. And then afterwards, we are going to explain the brain death condition, okay? But brain death doesn't mean anything for the population, while death does, unfortunately, okay? So this is really important to be clear. So the definition of a dead person, and this I suppose that nobody will see it as something new, is that it is an individual who has sustained either irreversible cessation of circulatory and respiratory functions. But here comes something new into brackets, because we are already since the late 60s or 70s, this concept is working, so it is not so new nowadays. But it is true that it's not only circulatory and respiratory functions anymore, it's also the cessation of all functions of the brain, okay? So any person that has these conditions is a dead person. And brain death is defined as the irreversible ending of the functions of all intracranial neurological structure in both the brain and the brainstem. And these, as I was saying, the first definition started with this ad hoc committee of the Harvard medical group, and that was in 1968. Okay, so since 1968, it has been recognized that the people can dead by respiratory and circulatory criteria or neurological criteria. So these criteria and this clinical situation has to be based on a diagnosis that has to be systematic, complete, and extremely rigorous. Okay, why? Well, because it's the most important diagnosis that we are going to say. We are declaring that someone is dead, that there is no other option for these people. So if there is no donation as an option, the next step, if we are, if we really understand that brain death is death, is to disconnect that patient from the ventilator, because we have a cadaver in front of us. Okay, so that's why it is so important to be very, very, very accurate while we are doing this diagnosis. Okay, and then we were going to see how to do the clinical examination. Another point that is really important, and Dr. Gamal has already raised this concept, is that it is a biological concept, it is a clinical concept, but of course there is a legal part of it, because we are declaring death, so all the time death is connected to legal procedures, but it is also, of course, cultural, and there is a social acceptation that needs to be there. But these cannot be a barrier, okay? So imagine that we are talking about a totally different clinical situation. Let's talk about diabetes. For us, it is not conceivable that the society do not accept diabetes as a clinical diagnosis, okay? Because we know that this is true, and this is a situation that can be diagnosed, that can be treated, etc. So in the case of brain death, it is normal that the general public do not understand or do not know about brain death, but it is our duty as healthcare professionals to know about it. It is our duty also to explain that situation, and it is our duty also not to have any doubt on that, okay? The big difference with the cardiocirculatory death till now is that after declaring the death under neurological criteria, there is hope, there is another opportunity, and this opportunity is donation, okay? So in the clinical donation process, one of the most important part is the death diagnosis, because we all agree that we only can be a donor of a living donor for kidney and for liver, but we cannot be a donor of 2 kidneys being alive or the heart. So we need the person to be dead, okay? And that's why we are mixing many times the brain death concept with the donation concept. And as also Professor Gamal just mentioned before, those two concepts should be separated, and brain death diagnosis should be an activity done in the ICUs in a routine way, okay? But inside the clinical donation process, after detecting the donor, after seeing and evaluating if this person could be a donor, if there is no contraindication for being a donor, and if the organs have a good functionality, in this period, because it's difficult to say if it's before or after, it will depend many times on the country, we need to declare the death of the person. And this declaration of death has to be independent from the donation and transplantation team. So we should have an independent team doing this diagnosis. And usually those people should be, one, should be the person in charge of the patient, because it is part of the courses of this patient in the hospital. And if this person is dead, the person in charge, the doctor in charge of that patient should be part of this diagnosis, together with another independent doctor, a neurology, a neurosurgeon, etc. Who will stipulate who should do this death diagnosis? As I told before, this is a legal procedure. So in this legal procedure, it is stated who should be the people involved in the death diagnosis. But in any case, it should never be anyone that is connected with disease donation or with transplantation. So this brain death diagnosis will be part of the end of life care of some patients in the ICU. So after a devastating brain injury, we will take care of the patient. We will do everything to save that patient. Then maybe there will be a neurological worsening, and then it might come a brain death diagnosis. And then at that time is when we are going to start having an eligible donor, okay? And we will have to manage those organs in the ICU in a very specific way. So our ICU doctors should be ready to take care not anymore of a patient, but of a body that has organs that can be transplanted. And as you can see, this is just an example on how in an ICU you can manage those cases. But the point here is that we have to be very clear that in the hospitals, in any hospital with neurosurgical services or unit, we can calculate that between 3 and 5% of all the hospital deaths should be brain deaths. Yeah, so these data come from an international benchmarking. That from all the ICU deaths, we should have around 10–15% of brain deaths. And then that's important because it's a way to see if in your units you are really declaring the brain deaths. And if it's not the case, you should see what's happening with those patients. And I can tell you that what usually happens is that these dead bodies are still ventilated for weeks in the ICU until the heart stops, okay? So we should all reflect on that issue, and we should reflect if it is ethical, if it is moral to maintain a dead body in an ICU, okay? Knowing then that there is such a big number of patients waiting to get into the ICU. Okay, so the only ethical justification and economical justification of maintaining someone in the ICU, not someone dead in the ICU, is with the unique purpose of donation. If not, it is something that it's not justificable. Okay, and another important point is that thinking about donation, from all the brain deaths we are going to detect in the hospital, only half of them will become actual donors, okay? So that's why it is so important so now I'm talking as a deceased donation responsible, to make sure we are not wasting any possibility in the hospital. So that's why the brain death patient's detection should be proactive by the deceased donation responsibles, okay? Good. Another important concept is that in Spain, as an example, the SEMISIUC is the Society of Intensive Care Doctors and Emergency Doctors. They have included in their key indicators of quality the detection of brain death. And not only that, also the generation of donors. Okay, so in a mature country like Spain in the field of organ donation and transplantation, ICU practitioners understand that having brain deaths is a good practice because it means that you are doing a good job in the ICU. You are detecting those people that are dead. And it is also a good practice to convert these brain death people into potential donors, okay? Well, this is another example too that was a quality, this is the quality system in Spain. And you can see that every year we audit the ICU deaths to see how many brain deaths were not detected. So that's another important thing. And as you can see here, from all the ICU deaths, 13% are brain dead. So the way how to, now I'm gonna get into the topic of brain death itself, okay? So as I was saying, this has to be a very systematic, accurate diagnosis. So we need to have a structured neurological examination. Once you have the law, you have to pick up the law and bringing back to the real life, okay? So every hospital should have a protocol of brain death examination. And this protocol should be the same all over the country. So that's why it might be a good starting point to work together, the Association of Neurologists and Neurosurgeons, to ask them to create a protocol of brain death examination. And in this way, and by creating a checklist, for instance, it can be an easy way for all the practitioners in the hospital to put in practice these diagnoses. So this checklist will be very useful because it will give precision and reproducibility, and of course, to avoid errors on doing it, okay? And it also gives, let's say, reliability on the system, because it cannot be different from one hospital to another one. It should be the same. It is one of the most important diagnoses that you are going to do in your life. So that's why it is important. So for the diagnosis, we will need to go through prerequisites. Then we will do a clinical examination. We can do the apnea test that can be part of this clinical examination. And finally, you might require to have ancillary tests. So I'm gonna go through all that. So, well, this is another message, but the important thing here too is to know where to do this brain death declaration. The way that is naturally the best place to do it is to do it in the intensive care unit. So you don't need to bring the patient anywhere. Usually in the intensive care unit, the doctor in charge of that patient has all the instruments to do that. It's a calm environment to perform the examination. And it's also the place in where the family afterwards, with whom you are going to talk and where they are going to see the relative. So it is the ideal place where to do it. So let's go to the prerequisites. First of all, we will have to make sure that the situation we have in front of us is compatible with the brain death. Okay, so we need to determine the cause of the structural and irreversible coma. So for that, we need to have a history, an examination, and maybe some images that are congruent, that make sense, that make us think about brain death, okay? Second, and very important, we need to confirm that there is nothing else we can do to save the life of that person, yeah? So that there is no other action that could change the situation. So we have to confirm the futility of any medical intervention with the neurosurgery teams. We have to see that there is no osmotic agents that might help his situation, or that we cannot do a ventricular drainage. Yeah, so that's really important. That's why, despite what many people think I'm always talking about healthcare professionals. Many people think that by working in brain death diagnosis and making brain death diagnosis to really happen in the hospital, that we are not going to take care of the people with a severe brain injury, but it's totally the contrary. The most accurate you are with your brain death diagnosis, the better care you will give to the patients, because in fact, you're going to be much more accurate on that. You're going to go till the end trying to save the life of these people, because since you know that at one moment you will have to do the brain death diagnosis, you're going to be much more proactive. Another important prerequisite will be to exclude the confounders of the situation. Okay, so any confounder that might lead us to have a false interpretation of the situation, we have to take it out of the picture. Okay, so what could be these confounders? Well, first of all, if we have depressant drugs, this might give us a wrong clinical examination. Second, if we have neuromuscular blocking agents during the examination, we are not able to look at the reflexes, because we are going to paralyze the patient. Third, you know that hypothermia also leads to a situation that depresses the nervous system, and that might also give us a false diagnosis. Any abnormality in the acid base or electrolyte or the tension of the patient, the blood pressure, these also will give us a false result of the examination. So to do the brain death diagnosis to a patient, we need to make sure that this patient is well monitored, that this patient is has the best outputs on the management. So he should be normothermic, he should be with a normal blood pressure, he shouldn't be under any drug that confounds. Okay, so that's also very, very important. And then if we have this situation, then we can go for the clinical examination and the apnea testing. So the first thing to do is to evaluate the Glasgow Coma Scale. I suppose that all of you know about it. 3 is the lowest number in the Glasgow Coma Scale, and it means that there is no responsiveness to any noxious stimuli, that there is no eye movement with any stimuli, verbal, noxious, whatever, and there shouldn't be any response of a noxious stimuli, but any other than the spinal or medular reflexes. Okay, those are some reflexes that can still appear, but this would be the first thing to see. And then we are going to go through the bilateral absence of brainstem reflexes. So to remind you which are the brainstem reflexes, we are not gonna go to which is the nerve or the nucleus that we are stimulating, because this is not a neurological talk, but it is important to do always the brainstem reflexes in this order. And why to do it in this order? Because this happens to be the reflexes that are, so the first that will disappear will be the pupillary response, and the last that will disappear will be the atropine test or the apnea test, okay, the apnea reflex. So that's why we are going to start from the pupillary and we are going to finish with the atropine or the apnea test. It also happens to be that those reflexes, the way how we stimulate them is also from the less noxious to the one that has a potential wrong effect on the patient. Okay, so that's why we have to be very systematic and always starting from and always following the same the same order in doing the reflexes. So for a matter of time and to give more time for the discussion, I'm not gonna go one by one. If afterwards you want and you ask me, I also have prepared the slides, but I think that what is important here is to remember what we are talking about. The pupillary response, what we are doing is to stimulate, to do a luminous stimulus to both pupils and to see if there is no response to the eye that has been enlightened and to the bilateral, to the other line, to the other eye also. Okay, so that has to be done always in front of all the doctors that are going to perform this clinical examination. I recommend that all the doctors in charge of the diagnosis to do it at the same time all together, because it's a way also to have I mean to do this in a consensuated way, and if there's anything to be discussed, to do it at that moment. The corneal reflex, what we are seeing here, so in the pupillary response, if the person is in brain death, it doesn't matter if it's meiotic or if there is meiosis or meiotic pupils. What is important here is to see that there is no response to the light. Okay, so in a brain dead person, nothing should happen in the pupils. In the corneal reflex, what we are going to do is to do a stimuli to the cornea. And usually if someone is alive, what happens is that you're going to cry, to have some drops going out from the eyes. You're going to have a red eye, yes, or you are going to blink. In a case of a brain dead person, none of these three reflexes should appear with corneal with a corneal stimuli. Oculocephalic reflex, the idea of this oculocephalic reflex is to move the head from one side to the other one and in a vertical too, and to look if the eyes are following the movement of the head. Just for you to get the idea, when you are doing that to a brain dead person is the same than doing that to a person who is dead and who is in the morgue. So imagine moving the head of a person who's in the morgue. What would happen? The eyes will move exactly at the same movements than the head because they are fixed. In any person who's alive, the eyes will not follow instantly. They will have a retard timing in the movement. In oculovestibular, what we are going to do is to stimulate the tympanus with cold serum or water, and in a alive person, something should happen to our eyes. Depending on the neurological status of the patient, maybe the eyes will go to the direction of the cold stimulation. Maybe it will go against in the other side, or maybe there will be only a nystagmus. In the case of a brain dead person, nothing should happen, and we have to do that also bilaterally. The facial movements have to do with the noxious stimuli. So we have to understand that if we do a stimuli in the cranial nerves area, which is all the area that is above a line that goes from the ear to the mouth, all stimuli is done above this line should have no reaction at all, nor in the face, nor in the body. But if we do any stimulus below this line, it might happen to have a reaction in the body, but never a reaction above this line. Okay, so that's an important concept. The gag reflex, usually the gag reflex is the way how the nurses will tell the physician and will say, I think that he's getting to brain death, because while I'm doing the aspiration, the patient makes no movement. And in fact, in this reflex, what we do is to insert a cannula inside the tube to stimulate the carina. And in any person who is alive, they should be a gag. Sorry, not the carina. I'm talking about the gag reflex. We go with a depressor at the end of the mouth. We are doing a stimuli to the area, to the pharyngeus, and usually the alive person will have a gag reflex, okay, or at least a movement in the abdomen. In the case of someone who's brain dead, nothing should happen. So that's why, while we are doing the gag reflex, we should look at the abdominal area. So we should take out the sheets from the patient and look if there's any movement at the abdomen or at the thoracic area, and also look at the monitor if there is no reaction. And for the trachea reflex, which is the one that I was saying that usually also the nurses will say, is that while they are doing the toilettage and they are doing the aspiration, they see that the patient is not doing any movement. Usually in persons who are alive, something should happen, okay? Even if they are really neurologically very much depressed. So we are going to do the same than for the gag reflex. Look at the abdomen, look at the thoracic area, and look at the monitor. And what we are going to do is to insert a cannula till the carina, the bifurcation of the bronchus, of the principal bronchus, and then something should happen if the person is not dead. And then looking at the atropine test, which is also affecting one nucleus of the brain stem, nucleus, if we administrate 0.04 milligrams of atropine per kilo to the person, any alive person should have a change in the rhythm, in the heart rhythm. In the case of someone who's brain dead, nothing should happen. We accept to have a small change in the heart rhythm of 10% maximum, because sometimes only by the way of just putting some liquid in the veins or doing this action, sometimes this will alter a little bit the rhythm, but it should never arise above 10%. So once we have done that, and we can also do, that will depend on the different legal procedures also, we can also do the apnea reflex. The apnea reflex concept is quite simple. The idea is that in any person who has a normal breathing, I'm not going to get into the point of someone with a chronic bronchitis or whatever, but in someone who has a normal situation, if we increase the CO2 above 60 millimeters of mercury, that person should breathe, okay? If we disconnect the patient enough time to see that the CO2 is increasing above 60, and during that time the patient has not breathed, it means that the person is not alive, is dead, okay? So to say that someone is dead through this clinical examination, all these reflexes should be negative, okay? So all of them should be negative. In case we cannot perform one of these reflexes, then we should do an ancillary test. Yeah, so imagine that you have a facial trauma, you cannot do some of these reflexes. So from a mandatory point of view, you should do an ancillary test. Another way is that to repeat this clinical exam after a period of time that it's totally arbitrary. It can be 24 hours, 12 hours, 5 hours. It depends on your legislation. And then the third situation would be to do the clinical diagnosis and then to complement it with an ancillary test. And in this way, you can do the declaration of death. How to do it? In this case, it will depend on your legislation. But by doing the clinical diagnosis, you can declare from a medical point of view that this person is brain dead. Okay, but of course, the ancillary test will be very useful because it will give us another perspective. We are going to be able to assess the neurological function and also the cerebral blood flow. And even for the family and even for the colleagues in the hospital, those tests gives an additional information that might be very important. In the case of neurological function, we are talking about EEG and multimodal evoked potential. The EEG should be isoelectrical, and in this case, it is isoelectrical. This curve that you see is only the heart, okay? And it has to be a standard methodology and done as you do any other EEG in your hospital. The multimodal evoked potential is less done in the world because it's a little bit more complex, but it's also useful. The absence of cerebral perfusion is a very simple way. It is clear and it is an acceptable criteria, and it's very easy for the people to understand and to demonstrate. So this can be done through angiography, through scintigraphy, or through transcranial Doppler. Okay, so here you can see an angiography and an angio-CT scan of someone in brain death. It is clearly demonstrated that there is no intracranial circulation. And why? Because the intracranial pressure is higher than the blood pressure. So it is what we call a functional decapitation of the person. If you show that to any colleague or to the family, people will understand what is happening. The same happens with a scintigraphy. Look at this. This is a normal control, and this is a brain death person. It is totally, there is totally lack of metabolism inside this brain. But if you look at a vegetative state, a locked-in syndrome, or a minimal conscious state, all of them has minimal but has activity. In the case of brain death, there is no activity, it is irreversible, and it is totally permanent. And the same happens with echo Doppler. Echo Doppler is very useful because you can do it in the bedside, and any people in the ICU can learn how to do that. In the other cases, you have to transport the patient to another place in the hospital. Another thing that you have to keep in mind is that once you have seen and you have declared the brain death of the person, then you can put some neuromuscular drugs to stop the activity. Why? Because unfortunately, sometimes what happens is that there is still some medullary motor activity. And this is a spinal reflex, but it can be very disturbing for the professionals in the ICU and also for the family. So sometimes it happens that by touching the arm, there is a small movement that appears, but you know that that person is dead. So it is recommended to administrate some neuromuscular blocker at this moment. Then another important concept is that, unfortunately or fortunately, it doesn't matter, but that brain death declaration has not only the clinical aspect, but it has a legal aspect, okay? In fact, brain death declaration is the only diagnosis in Spain that is included in our law. And unfortunately, it is inside the transplantation law, okay? What makes this controversial aspect. But it is important for you to divide very clearly what is clinical and what is legal. A brain dead person is the same in Egypt, in Portugal, in Spain, in UK. The point is that from a legal point of view, the way how to do it or to demonstrate it might be different, okay? But you as a doctor can be totally sure about you because you know when someone is dead or when someone is alive, okay? So it is important always to document the brain death in the records. And a very, very important point that seems to be very obvious, but it is not in most of the countries, is that the time of death, of a brain death situation, is when you finish the test, okay? So once you have finished your clinical test or you have done your ancillary test, this is the time of death of the person. So I've seen in the world many strange situations. Sometimes the death is declared at the beginning of the organ retrieval. This is a very awkward situation because imagine what the family will think if they see that when you told them that the person was dead, he was not actually dead. He was dead when they took out the organs from that person. So from a rational and clinical point of view, what makes sense is that the time of death is the time when you finish your clinical and ancillary examination. Afterwards, we can discuss if this happens or not in Egypt, but those are concepts that as doctors, not as legislators, has to be totally clear, okay? So once we have declared the brain death, then is when we start the donation process. But we shouldn't be, as I said before, we shouldn't be part of the team of the brain declaration. So I can finish with that. I think it is important as messages to make clear that brain death is equal to death. And when we talk to the family, what we have to inform them is about the death of the person. And then once they have cried and they have understood that the person is dead, then you can explain the special situation of brain death in where they are going to see that the person is breathing, that it's, but even if you don't mention brain death, it's fine. The important concept for them to understand is that their relative, unfortunately, is dead. Another very important thing is that this is a clinical diagnosis that should be independent from the organ donation process. And in any ICU in Egypt, nowadays, you should have brain death, you should have brain death cases. You should have declared people dead through the or under the neurological criteria, despite you are not doing donation. So that's why it's something you can implement from now on, even if you don't start disease donation. The diagnosis has to be based on a clinical examination. This is the core of the whole thing. It's not only by doing echodoppler that you do it. You should have the clinical examination completed. And as I was mentioning, as a good practice, ICUs should incorporate brain death diagnosis as part of their KPIs, of their key performance indicators. And then another one that I also want to transmit you is that we always blame the population, because we always say, no, the population is not ready for understanding brain death. The question is, I'm sure they are not, but are you, the healthcare professionals, ready to really understand and say that brain death is equal to death? Are you ready to do that? Do you think that all your colleagues understand brain death as the death of the patients? Because here we are going to, in the process of donation, the hospitals and the healthcare professionals have the major role. So we tend, us clinicians, to blame the national authority or the law, or sometimes the population, because we believe they are not ready. But I think we have to be very critical in a positive way, in a constructive way, and to look first among our hospital, our colleagues, and start there. Start from where we are, start normalizing the death declaration by neurological criteria, and talk about it, do seminars, be informed about that, do some surveys in your hospital, and you will see that your colleagues, nurses and doctors are not ready for that. So that's why this is about knowledge. This is about knowing about that. So you need to train on that. So shukran, thank you very much for your attention, and I hope that this talk was useful for you.
Thank you very much, Chloe, for the great talk and great presentation. And actually, we might have some aspects to discuss with you. I have myself 4 or 5 questions for you, but I might delay my questions until we get the chairing of other colleagues before me first. Do we have any questions from the floor, Dr. Yasser?
Still not having a question. They are writing their question sequentially, but I have a question for me. Thank you. Thank you so much, Chloë, for this very, very interesting talk. It's really one of the best I have watched over the past 2 years in this platform. You said that in the final of part of your lecture that you should use a neuromuscular blocking agent because you can have some movements. And in the assessment of the reflexes, you said that expose the abdomen, look for the monitor to watch for a very minute movement responding to the reflex.
Yeah,
so
this is after. Once you have declared brain death and you have done all the examination, it is a good practice that now you're not going to do the reflexes anymore. It is a good practice to put neuroblockers, because if not, you might have this possibility of having this body moving because of spinal reflexes, and this will give a very bad, it's a bad input for everybody, for the patient, for the families, but it's after the examination, always after, once you have declared death.
But if we accept for the presence of a minor movement, at any time, so the reflex will be positive at this time. Do you agree with me?
No, because as I was explaining you, when you do these noxus reflexes to see if there's any movement, what you are only looking are this part of the face. Yeah. So all that is above this line that I was saying. So all the territory that has to do, that is under the control of the central. Exactly. So that's what you're going to look. It can happen, no? So if you do a stimuli here, nothing can move because you will not have any spinal reflex by doing that. So if you stimuli in this territory, no movement should happen, nor in the face, nor in the body. But if you do a stimuli here or here in the thorax, it might happen that you will have a movement in your body, but never
from the upper, related to the side of the stomach.
Yeah.
Thank you very much.
Thank you.
I might have several points to discuss with you, Chloe, first. You mentioned one issue which is probably of an ethical background rather than a medical background. You mentioned that after diagnosing brain death, probably in the ICU will be giving more care to the dead body to preserve the organs and so on. So this might be ensuring to the family. I differ with you.
Yeah, I think I didn't express myself clearly.
Yeah, I'm sure. We need to have the utmost care given to the patient to maintain his life. And when we fail, we maintain the same level of care to preserve the body.
Exactly. What I wanted to mention is that when you perform brain death diagnosis in an ICU, and it is a common practice, you will see that the care of your alive patients, the care of the neurological injured patients will improve, because since everybody knows that if I mean, it's like the team become more proactive, because they know that they have to do everything they can, because if not, they might go to brain death and they will declare brain death. That's what I wanted to say.
Yeah.
But of course, the care of a brain death patient because of organ donation is very intensive, very much intensive, sometimes more than another patient, because you have no control from the central system.
Yes, I think one of the most important crucial points is that after diagnosing brain death in the intensive care, we should include the anesthetist who will be responsible for the procurement process at that moment, to share with the intensive care specialist the care to the dead person. And by that moment, we should consider also giving all the muscle relaxants. And I need to expand as well that during the procurement process, the dead person needs some anesthesia as well, which does not mean anything that he is having any reflexes or incomplete diagnosis or so. So this is very important and crucial to clarify to our colleagues and intensivists and surgeons as well. Another point to be discussed is that in Egypt, we have the brain death criteria among the organ donation law, but it is not present among the declaration of death principles. The declaration of death in Egypt is dependent on circulatory death. And any trials to reintroduce the declaration of death according to brain death criteria will cause a lot of hassle, and we might not get out with the law. So I think we as a good start in Egypt, we should depend on diagnosing brain death and wait until we have circulatory death happening. This is mandatory to start the program in Egypt. And I think when we consider stopping the ventilators or the circulatory assistance for 5 minutes, we can consider that this is a suitable enough time to consider the occurrence of circulatory death following brain death. And the time from brain death to circulatory death will be an initiative to start our preparation for tissue typing, for searching for suitable recipients, and so on. But it is mandatory to start the program in Egypt is to await circulatory death after brain death. You agree
one
with
question? Yeah, one question is, if I'm not wrong, there is a law that passed during last year in Egypt regarding that. I think that there is an evolution on the law. What I mean is that if you don't have
for the law, but it was not implemented yet.
If you don't have a law about brain death,
yes, yeah,
of course you have no issues. You have to wait for the circulatory death. But there comes a problem, because it's what we call DCD type 4. So it's someone who's dead, but you have to wait for that. There is a country that I know very well, that is China, in where they don't have a law for brain death. And what they have done is to get national protocols from the neurological society, so I don't remember if it was the neurologist or the neurosurgeons society, that they have created national protocols about the diagnosis of death, and they have been approved nationally. And in this way, it is approved that the death of the patient can be declared by neurological. So it will depend one country from another one. The problem of waiting for circulatory arrest in a person who's brain dead is that unfortunately, this will not occur on the first days. It will take long time. During this time waiting, the function of the organs will decrease.
Sure,
So the
sure.
quality will not be the same. So what I would say is that, of course, you have to follow the rules of your country, but you have really to push this to be changed or accepted, or to find other ways to go for that, because if not, your first cases of deceased donation will not be optimal. And
yes,
for the first cases,
I'm sure of this, Chloe. I am sure of this, and probably as a start, we might also include considering only kidneys or kidney and liver transplantations at the beginning. Yes. Only. Okay. Another issue is that if we encounter cases of circulatory death or cardiac arrest, and yes, we are advocating to implement the brain death, would we consider, after circulatory arrest, awaiting for brain death the opposite way, to be sure that our advocation is correct, or we start the procurement process after circulatory death without having full criteria of brain death?
I think you cannot mix that two things. I mean, I think that from a good practice point of view, and also an ethical point of view, you should declare brain death always from yes, a clinical point of view. And then you wait for the arrest, and if the arrest is the legal time of death, just put it. But in the records, start putting the examination of brain death, because if not, your people, I'm talking about awareness of healthcare professional. If you don't do that independently from donation, or if you don't do that independently for the law, people will relate always these two issues. And that's, I think, and I don't know, Dr. Faisal from Saudi Arabia also has experience. They have the law, but I think you will agree with me, no, Faisal, that it is important to do it, even if the law is not there, to make sure everybody is comfortable with these diagnoses when the law will come.
So, Professor Faisal, please unmute yourself to answer this question.
Thank you very much. Sure. It is excellent talk, and we have experience, a very long experience with the brain death diagnosis in the kingdom here. And I agree with you about many points which you shared with us. It is essential, especially when to declare the brain death as a death. This is one of the important issues which I faced during my work, and I struggle a lot in order to make the death declaration is the time when we diagnose a brain death, which is very important. And even I went all through, but still the people don't accept it. How the patient, or whatever, he's a donor, anyhow, he died 2 days back officially, because we are in Islam, inheritance is important, about marriage, about inheritance, about many other things. So exactly when he died, because this from the time of this is important for the inheritance, for marriage, for many things like this. For women, when they started to when they can marry again, or when her menstruation will finish, something like this, very important issue for us. So hopefully, if someone have the law, he put this as the first declaration of the brain death is the time of death, which is medically is important. About another things about the DCD or DVD, you cannot mix it together, Prof. Jamal. DCD is circulatory death is different from brain death, and if anyone had circulatory death, for sure he had a brain death, and the brain death is more documented than circulatory death. Brain death, you can, if someone had a brain death, it is a death, end of life. But circulatory, if you have someone who is cardiac problem, you take his heart out, perfuse it, and then return it back. It will work again, and he is not at this. So we cannot mix it together, and it's better not to mix it from the start. But I know the situation in some area that it is not easy for them to document a brain death because of the whatever religious aspect, because of the culture issue. It's okay. It's happened in Japan. Long time they are making some sort of circulatory death, but they are dealing with the brain death different way. They put machines, they circulate inside the body fluid in order to keep the organs, viable, in order to retrieve them after circulatory death. And this is now they overcome because they recognize the brain death now. But this is one of the things. In China is the same. So again, circulatory death, I know that some people will say that we will accept it as a culture better than the brain death. This is no. I am sure not. If we accept the brain death, accept the donation, we can accept circulatory, DCD, or DBD. And we should work in both together, not only one side. This is, again, very important. Again, the point, sorry, I'm sorry, Dr. Yasser, because of the spinal reflex is important. Spinal, to abolish it is very important because it is a triggering of refusing the doctor to document the brain death. If they don't know that this reflex is coming from the spinal, and the dead body start to shaking during operation or something, they may stop, even not to do anything. So probably to give them, calmness is to consider spinal reflex and give them some muscle relaxant in order to proceed. And for anesthesia as well, we have to deal with the brain just like any patient who's going for operation. Either he's going for cholecystectomy, for anything, we have to deal with them exactly the same. Sterilization the same, to deal with them, respect the body. All of this is very important in order to promote. It is very important to do that.
Okay.
Probably my questions again, but which is maybe you didn't mention about hormonal.
In short, please, Professor Faisal.
Okay, hormonal therapy for the brain disease cases. You didn't mention that. Probably if you can just tell us.
Yeah, well, this is in the management part. No, I just talk about the brain death declaration. But once the person has been declared dead, we will have to take good care of all the organs and all the functionalities that we will have missed. So with the brain death, we also miss all the hormonal, the hormonal flux coming from the hypophysis and so on. So we will have to work on that specifically. And there are also, it's still not completely proven, but there is even the treatment with thyroid hormones, no? But yes, this is in the management. This is the second talk that I will that this will happen, no? How to manage, but this is for ICU people.
Okay, we have some questions on the chat. Thank you, Professor Faisal, and thank you, Chloë, for your response. We have some questions on the chat from Dr. Jacqueline Shu. She is asking, when after diagnosing brain death, do you remove the organs? Asking about the time plan.
Well, yeah.
Do you keep two questions? She has two questions. 1 second, please. Do you keep the brain death in the same ICU room until organ retrieval, or you need a special room? Your administrative part here.
Okay, great. So first of all, once you have declared the death of the person, you have to talk to the family, and this might take more or less time. And then you will have to do all the evaluation of the donor to make sure that there is no contraindication, no active infection, active cancer, and other absolute contraindications. And you will have to also look for the viability of the organ itself that you want to transplant. Yes. So this will take a time. Nowadays in Spain, after the brain death declaration, usually the retrieval is always less than 1 day. Okay, but this is not everywhere. In some places, it might take longer because the procedures might take longer. But my answer would be, the faster you could go, the better results you will get in your transplantation. And then where to take care of this dead body or of the organs of these brain dead person, in the ICU. The ICU is the best place where to do it. In the United States, in some cases, what they do is to transfer them to a special facility, the OPOs, the organ procurement organizations. But from an efficient way of seeing that, it can remain perfectly in the ICU and taken care by the ones that are trained to do that.
Okay, thank you. Another comment and somewhat a comment from Professor Hisham Sayed, the Vice President of Egyptian Society of Nephrology. How can we convince people for disease donation, and especially your expert in this? It is a conceptual one, and I think starting the project in Egypt should first have a social work to stop thinking in this pharaonic way. Do you agree with this?
Well, how to approach to the family? You have to approach in a professional way. That's the first thing. You have to know exactly everything about the process. So the one that will be talking to the family should be someone trained to do that, to know how to give bad news and knowing all the procedure of donation. Then regarding the society, once more, yes, the society is the final beneficiary of donation, and it's also the source of our organs. But if I had to start somewhere, I would start by the professionals. Because if the society is ready and in the hospital we are not ready for that, then we are not gonna gain anything. And second, because the healthcare professionals community is smaller than the population, so it's easier to do actions with them. And third, because if the healthcare professionals people are trained and know about it, they will be doing the awareness to the population in a soft way. Okay, so I would start by the healthcare professionals.
Okay, thank you. From a question from Professor Kamal Okasha. He is the Vice President of Tanta University and one of the ESNT board. He is thanking you for your excellent presentation. The question is, when the exact time to go harvesting the organs? I think you answered this, but if you want to add your answer. And the second question is, do you have to tell the family, even they consent the patient having a donation card? If the patient having a donation card, do you are to take consent again?
I would say yes. Always you have to talk to the family. It doesn't matter if there is a card, it doesn't matter if there is a registry, it doesn't matter what kind of legal procedure you have in your country, opting in or opting out. Why? Because the ones remaining in this world will be the family members. And you cannot proceed without informing them well about what's happening. If they understand exactly what's happening and then they know that their relative wanted to donate, they will accept 90% of the cases. But if you only tell them, he had a card, so we are going to do the retrieval of the organs, then they will be against. And they will give very, very bad news about that. They will release a lot of bad things about the procedure. So it is our clinical and our expertise and our duty to give good information to the people, to the families, and then to make them understand what's going on. And if there is a card, I'm telling you that from my experience, few of them will say no. It's very rare to be against a dead person. But if they don't understand, then yes. But if you really do a good job, it's not going to happen.
So in the view of shortage of organ supply, you advise against not doing transferring organs against family, even if the patient having a card, a donation card. This is your advice.
Absolutely.
Yes.
Absolutely.
Clear message. Professor Hisham Said is thanking you specially. And a question from Professor Said Khamis, the head of nephrology unit in Menofia and one of the team preparing for this cadaveric transplantation with Professor Gamal. He's thanking a lot for this very elegant lecture. From your experience, how could you implement the concept of acceptance by the society rather than only the awareness of deceased donor program? How to deal with the society apart from only the awareness, other methods? And the second question is regarding liver transplantations, purely a scientific one. What is the optimal pre-operative serum sodium in the potential recipient, and why there is a phobia from ODS, especially in this patient, osmotic demyelination syndrome?
Okay, good questions. So once more about the society, I think I'm repeating all the time the same, but I think that what is really important is to get the trust of the society. So if you are doing transplantation and they see that the people has access to these treatment, and if they see that the results are good, they will understand then that donation is an option for them. And also the confidence with their healthcare professionals. That's super important. So sometimes we are putting effort in trying to convince people about the beauty of giving organs and so on. I think that more important than that is to give an image of professionalism and an image of the good results of transplantation. And finally, regarding liver transplantation, any organ, what you need to have is the levels of all the electrolytes as normal. That's our goal. Yeah. And sometimes because of brain death, there might be some changes, but our goal is to put them in normal status. That's why maintenance of organ donors is so important, and it's so difficult also, and so time, I mean, it requires a lot of active care of the care professionals in the ICU.
Okay. A comment from Dr. Mohammed Abdelbari, professor in military hospitals. He is commenting, we must start from ICU doctor education, awareness of brain death, and to be as KPI. And to Professor Ahmed Abdel Alim with us. And can we change our certification of death in ICU? And Professor Ahmed, I think there is a problem in his connection as I am asking him to unmute. Yes, Professor Ahmed.
I have no problem.
Yes, he
just
came
waiting
again.
Everybody to give his opinion.
We want to know answering this question and know your point of view in this talk.
Yes, first of all, I'm a neurologist, so we'll talk from my perspective, and also I'm a director of a stroke unit in an ICU, so we see many cases of brain death, and of course there's a problem in Egypt that we don't have a clear criteria, and we only develop the criteria just for the transplant. And I really respect what Dr. Chloë said, that we should separate the brain death from the donation. And I think this is for the good of the nation also, because we have to change the culture in accepting the idea maybe that maybe someday we can declare the brain death as an actual death. And I think that the religious authorities in Egypt has shown flexibility with the brain death, and they always rely on the medical opinion. I think this may take time, but it will. We need to separate the brain death as a thing. Start with the doctors and then with the public, and this I think may help. And then it would serve the transplant if people accept the idea that a brain dead person can maybe later on become a donor. Another thing that I might be asking Dr. Chloë, it's a totally different perspective about in countries like Egypt, if we have a national criteria for brain death separate from the donation, then we need to provide all hospitals with ancillary tests to be able to fulfill the criteria, because I think we cannot fulfill the criteria without having ancillary tests. This would incur a cost because maybe in big hospitals like government and some military and some of the big hospitals of the Ministry of Health, they have the equipment. But if you go a little bit peripheral in smaller hospitals where they have ICUs, then how can a brain death committee operate in such situations? So should we have like committees within every hospital or regional? And who will cover the cost of the ancillary tests? Is it the hospital itself? Is it the insurance? Because at the end, somebody has to pay for these tests. I'm talking, of course, from the perspective of someone who works as a director in the ICU. So I will be asked to provide the ancillary tests. I will go to the hospital. Please provide me with an angio and an TCD and things like that. These have a cost.
Your questions are really important, and I think that here takes the part of all the cost incurred by the donation process should be covered by the hospitals and reimbursed by, depending on your coverage, by the insurance of the transplant of the recipient, by the government if it's a public system, but it has to be part. In any case, any cost should be paid by the families, never anything that has to do with donation. I mean, it's not ethical. Second point about the ancillary test. You always have cheap possibilities. You can use echo Doppler. That will be very useful for ICU people, and ICU people can learn a lot by using Doppler, transcranial Doppler, even for the treatment of their patients. Another option is to have, as you said, a committee in a big hospital, and when there is a case of potential brain death, they can go there and do it. And then, of course, this has to be paid, yes, or has to be compensated in any way. But there are options. And the other option is to do 2 clinical exams separated with a time frame. This is always, in all the countries, it is accepted that 2 clinical exams separated by arbitrary time, 12, 24 hours, whatever. Don't do 24 hours, better do 6 hours. If both of them are positive for brain death, then it happens, okay?
Thank you. Excuse me. Thank you, Professor Ahmed. Thank you, Professor Ahmed.
I have my input here, Dr. Yasser. I think considering the expenses, we should consider that putting patients on the waiting list and on receiving organs, there should be some payments for this recruitment process, including the expenses of the ancillary test or whatever. Once you receive an organ, there are expenses which the recipient should pay, not by himself, basically, but probably by the insurance or the governmental coverage the patient or the recipient is covered by. If he is a private, so he will pay it out of pocket. These are expenses related to the organ supply. So it is not a matter of a preparation of organ and who will pay for it. The recipient side should be considered in that aspect, whether to be paid by the insurance, by the government, or out of pocket. So this is an important issue. The other thing is to gain the trust of the community. All the process should be coded and not centrally coded. It should be coded among the waiting list centers themselves to provide trust of justice, of distribution, so that the government or the authority will not be blamed that they are getting organs to distribute them on their special prioritization. This is an important aspect to gain the trust of the community. So these are the 2 points which I would like to add.
Thank you very much.
Thank you. Thank you, Professor Gamal, for this. And I think we can close by this comment from Professor Gamal and from Professor Ahmed to close this very, very interesting session. We lasted about more than 1 hour and 30 minutes. And thank you, all professors. You received many, many thanks from Professor Hisham, Professor Kamal, Professor Saeed. And special thanks to Professor Gamal Saadi to be with us, Professor Ahmed Abdelalim to share us in this session. And thank you, Chloe, for this very, very interesting session.
My pleasure. Thank you.
And we are looking forward to have a complete session about brain death in our coming Congress next January, and hope you will be with us face to face, Chloe.
I hope so. Inshallah.
I hope so.
Thank you.
Thank you very much, all.
Thank you to all of you. It was a pleasure. Thank you. Shukran.
Okay, it's time to close.
Bye-bye.
تصبحوا على خير. السلام عليكم ورحمة الله وبركاته.
وعليكم السلام.